Apollo Hospitals, Jubilee Hills. He has many degrees to his credit. He is an MD, FNB, and he has a European degree in critical care, and is a teacher, ECMO fellowship. He's a lead consultant, ECMO, advanced critical care. The area of interest are extracorporeal therapy, mechanical circulatory support, healthcare administration and operation. Today he is going to present a topic on his experience with ARDS, the storm in the lungs, calming the tempest.
Good morning all. So thank you Manipal team, the entire organizers, Dr. Lokesh and everyone available here. So over last two talks from Dr. Neha and Dr. Vishnu. So we started from the MBBS, the microbiology book. Probably they covered the entire microbiology. Like they were hardcore clinicians. They took into the evidence, studies, and so many things. So for a moment, we'll come back. Okay. So the reason is I'm privileged. There is no great studies, no great data on that topic. What I'm going to talk here. Oh, sorry. Is it working? Excellent. Okay. Yeah. So that's me. I thought of starting my topic with a case. So the topic given to me is the evidence versus experience. Again, I told you. So it's because there is no much of evidence, I can escape. So with my experience, and let's see what the experience, and we'll try to share and try to understand from you people, how do you deal these cases. So our patient is a 25-year female, not having any comorbidities. On day 5 of ventilator, day 5 on ventilator, came from some other hospital. So the team has done an excellent job. They have proned 3 times, and this was the CT. So this is very common. It's nothing new. We get this kind of patients left and right. Viral pneumonia, ARDS. Till now this is fine. Now this is something scary. Are you happy? It's like the roller coaster if you have been to Wonderla, there will be one jumbo ride, okay? So we all feel excited because we feel we escaped of death. That's what it is. So here, now everybody's adrenaline will in rush. The pulmonologist, the physician, the family members, even the hospital administrator also. Because 33-year female, they came with a great hope to your hospital, and you told you have all services, please do come, we will provide. And right now this is the situation. Now, so we'll try to understand, so what is right or what is wrong went with this patient, of course not treatment wise. So we'll talk about the evidence or the guideline wise, and the rescue mechanism. So what can be done here so that the 33-year female with 2 kids, she can go home. Fine? So now we'll stop the case here. We'll again in the end we'll try to understand what actually we did. So ARDS, again, there are so many definitions. The definitions keep on changing every 4th or 8th years. The recent definition was 2012 definition, Berlin definition, they told. Again, these are heavily criticized because the ARDS, they are very, very obsessed with the X-ray findings, the hypoxemia and other things. The recent concept, recent definition says ki come out of those, the hypoxia and the X-ray findings or the radiologic findings, focus on the pathophysiology and see what can be reverted. That's what the 2023 update of ATS says. So ARDS should be looked differently apart from the hypoxemia, apart from the radiologic findings. So now this slide will again keep on repeating. So ARDS lung has 3 areas. One is the basal consolidated of the collapsed lung, nothing can be done. Okay, momentarily it's not working basically. The middle zone is the openable or recruitable or whatever name you give, okay, the middle zone, and the upper part is called as baby lung. So you would have heard so many times, so many in conferences people talk on the baby lung. Now what is the baby lung? Baby lung is basically the healthy lung, the part of the lung with which this lady is living. So now what is the problem? So whatever you do, the aim should be not to disturb, not to damage, or to at least to salvage that part of the lung. So we have understood this is nothing new. Since last 15 years, people understand there is a baby lung, and probably now the problem is there is no exact mechanism to estimate what is the volume of baby lung. Some says it is 6 ml per kg body weight, some say 4, some say 2, some say even less than 2. So there is one study, they have estimated CT guided volume estimation. You will be surprised, they estimated in a severe ARDS, the volume even 2 ml per kg body weight over distanced that part. That means the mechanical ventilation, the long safe ventilation, low tidal volume ventilation of 4 ml per kg body weight, what is taught in every conference, that even destroys the viable part of the lung. Now how to salvage? Again, two theories came. There are two ways. Either don't ventilate, because once you ventilate, you damage the viable portion of the lung. If you do not ventilate, then probably you will not. But again, if we do not ventilate, we'll see what all options are there. So this is the mortality in ARDS. If you say if you see 2080, it was around 60 to 70%, but now also the study says it's around 35 to 40% mortality in ARDS. And so much so in severe ARDS, it ranges up to 45 to 50%. That means since last 10 to 15 years, whatever research has been done, so the mortality is still in the same range. Now, so this is what the cause of mortality in ARDS patient, multi-organ dysfunction, okay, and the respiratory failure only 18%. So when we were taught in the resident classes, so they told, look, no one dies of hypoxemia. So this is one NEJM article, so I specifically wanted to quote it. The reason is how much hypoxemia someone can tolerate. So there is one research group, they try to understand people going to Everest, and in the peak of Everest, they try to analyze the PO2, ABG. So from the Nepal base camp till the peak of Everest, the lowest PO2 is around 40, and those people, they came back, they lived their life. That means probably hypoxemia is not our enemy. So that's not a problem. But we keep on trying, if we keep on addressing the hypoxemia only. Okay? So that's what we need to clearly understand, that in ARDS, it is not the hypoxemia which kills, or not the primary pathology which kills. It is the secondary pathology, secondary damage, or the subsequent problems what happens because of our false understanding or false way of treating the ARDS patient, that kills them actually. So this is what causes the multi-organ dysfunction. So now further analysis, so there is a ARDS net trial till now from 2003 till now they have collected near about 57,000 patients data. So they further analyze the cause of the multi-organ dysfunction. There is an entity called as VILI, that is the culprit behind this multi-organ. So if something can be done to prevent or to protect or not allow patient to go into the VILI or the ventilator-induced lung injury, then probably that 66% of the death can be prevented. Even if not 66, at least it can be controlled. Now let's see what are the options available to tackle VILI. So now to prevent VILI, you have the option, do not ventilate, but you can't do because our patient is having air hunger, having a workup breathing which is significantly high, that need to be addressed. So let's see now little bit about the ARDS again. So this is what the guideline based. Again, every part of the treatment has its like pros cons, but proning, something which people thought it's the gold standard treatment. Again, there are so many questions came on the proning. We'll go into details. Then steroids, I'm not going, okay. So there will be a lot of controversy, all being pulmonologists. It's a very emotional topic for so many people basically. So some say 60, some say 120, some say 20 is also more. Fine, we'll not go into that controversy today. And it's because I am a ECMO specialist, my talk will be little inclined towards the ECMO service in these patients. ECMO, then low tidal volume ventilations. So this is what is the ventilator causes the damage. Now whenever you ventilate a patient with a relatively high volume, the baby lung, the viable part of the lung goes away. Now to come back to our patient, a 33-year young lady on day 5 having a hypoxemia and coming, Despite of the team treated with a 4 to 6 ml per kg body weight, the reason is probably on day 5th she lost her viable lung and she came to us with hypoxemia. Now, I'm not telling it's wrong. They did absolutely right in terms of the guideline. They have done the right job. Then comes, so how much volume is low volume? So around in 90s, 15 to 12 ml. Of course, now we are not going to that high volume. So people, by 2016, they told 6 to 4 ml. So recently, if you see, even 4 ml is also high, as I quoted the trial. Now, how to decide on the ventilator? So again, now not to ventilate is the best way to avoid ventilator. Either before going to ventilator or after going to ventilator, we'll do something so that this patient will get protected from the villi. So there are two ways basically. One is the HFNC. This is the I can say it's like a gift which came to the mankind, because putting a NIV for 2, 3, 4, 5 days was a way cumbersome and it was very difficult for the patients. At least HFNC, and the ATS recommends, we recommend to use HFNC. Okay, that is a very good thing. In between HFNC and NIV, there is no great difference. So at Apollo, we usually use HFNC, and of course in many centers they keep on using. Next, coming to proning, I'll quickly go into the proning. There is no question in the benefit of the proning. There are so many studies and people left, right, since last 10 years, people have learned so many things after this ProSeva came. But there are some concerns over. Now, there are two guys basically, both are Italian. The ProSeva guy is the Guren and another guy is called Gattinoni. They both are friends, but they do trial in two different directions. So this is the Gattinoni's trial was ProSeva, who told, look, there is a tremendous benefit with the proning. The ventilation perfusion mismatch can be matched. So many physiologic benefit he explained. Then came, so in a meta-analysis, so this is by Guren, his friend, sorry, it's going. So this is by Guren. Now he told, fine. So what is the percentage of patients who get benefited when we prone? 90% maybe 99% of patients also. Severe ARDS, when you prone, every patient will show some improvement in hypoxemia, will show improvement in the hypercapnia also. That means there is an improvement in oxygenation, improvement in the ventilation. But still the outcome of ARDS is same, mortality is same. So before ProSeva, after ProSeva, the mortality is same. Then he told probably something wrong is going on. He went and analyzed near about 17,000 patients who underwent proning. This data shows even if patient shows the oxygenation improvement and carbon dioxide improvement, it is the driving pressure. If the driving pressure is still high, irrespective of your hypoxemia, hypercapnia improve, that patient will die. So the world suddenly they thought, what went wrong? So since so many 10 years we were practicing proning, now he told no, it's not a no to proning, you prone. Now the next question is whom to go for second proning, whom to go for third proning. You need to know precisely. It is not only isolatedly on the basis of the hypoxemia improve, saturation improve or the carbon dioxide improve. Also there should be a driving pressure, that is nothing but the plateau minus the P. So if in those patients where the driving pressure came down with hypoxemia and hypercapnia improvement, they are the only subset patients who are going home and other patients are not. That means the idea of proning suddenly changed, and probably they are coming with some nice recommendations on proning. But again, I don't deny for proning. We should go for proning in severe ARDS patient, but we should know whom we should go for a second, third or a fourth proning. Then coming to the topic which is close to my heart basically, okay, is because I told you in the beginning I practice ECMO, so my talk may be a little bit inclined towards ECMO. Then comes one more way not to ventilate is, of course, once they go, I told you should do everything so that they will not go to ventilator, and of course we should do everything so that they will not go to ECMO, but they should not be on the ventilator also. Now what to do? We need to do something so that the villi, the culprit can be avoided. Now in the ECMO, so over last decades if we see, there were so many trials, but at least these are the randomized trials. So all in NEGEM, one in NGIX, then Caesar, then Eolia. The recent one is the Eolia. So with a 10-year gap, The Caesar told, okay, there is a tremendous benefit of ARDS patient, severe ARDS patient. If you do something, put them on some machine and bring down the ventilator setting so that the baby lung can be protected. That is a gross idea. Subsequently, after 10 years, the EOLIA told, look, we are not finding a great difference even if you put on a ECMO or not ECMO. But subsequent to EOLIA, and EOLIA has so many demerits basically. So now, what is the difference between 2009 and 18? So many trials came, though people learned a lot about the non-ventilatory management of ARDS. That's what is contributing to the outcome. We'll quickly go into, these are the things. So how to select? So suppose we have 10 patients on ventilator. We need to have 2 scoring systems. This is what the residents should learn. We should have to have 2 scoring systems to satisfy to take a patient on ECMO. First is whether the patient requires ECMO or not. Patient, severe hypoxemia, severe ARDS, proning. Again, fit for second proning, not fit for second proning. Then you need to have a scoring. So worldwide, people use Murray score. Now at Apollo, we use Murray of more than 3.2 as the cutoff to satisfy that yes, this patient requires ECMO. No, but that's not sufficient. Suppose you are getting a 10 ECMO calls, maybe we take 1 or 2 patients to ECMO, because there is one more scoring that is called as the outcome scoring. So that will tell us whether the patient will get benefited from the ECMO or not. That is RESP scoring. Okay, that is there in my slides. I'll tell you. So a patient having a RESP score of -4 to +4, the score is -8 to +8 basically. +8, they don't require ECMO. -8, they will not get benefited for ECMO. So -4 to +4 of RESP, a Murray of more than 3.2. These are the 2 patients who medically they require ECMO and they benefit from ECMO. After that, there are so many things, the financial, the emotional, so many things you need to consider. It is not very easy. So, yeah, let's quickly go from these slides. Yes, this is the score what I was talking about. For every patient, whoever meets the Murray score, a RESP scoring must be done. That's what worldwide people practice. Also, the Extracorporeal Life Support Organization, they have given these guidelines. So I told you -4 to +4. Below -4, the outcome is below 20-30%. Even if they have maybe living in Jubilee Hills, having 500 crores of property, the son is in America, they want everything to be done, doctor. So probably say, boss, it is not the right modality. And more than 4, probably you can get away without ECMO. Okay. So these are the objectively, these are the 2 scorings apart from other indications. We are not talking about a VA ECMO, it is specifically for the VB ECMO. Now in terms of VB ECMO, there are so many trials. So survivor versus non-survivor, they analyze now what is driving the survivors, non-survivors. It is once you put a patient on ECMO, you come down on the ventilator setting, come down on the pressors, you save that baby lung. That's what is the viable, and slowly now the lung need to rest, lung need to recover or heal. That will start from the healthy lung. If you damage that healthy lung, then probably it will take a longer time and recovery will be questionable. So just I told you now, so suppose a patient is prone, and again objectively to tell, patient may go for second proning if those criteria are setting. If your driving pressure is still in the range of 16, 17 or 18, then probably it is better to consider ECMO, even if there is a hypoxemia improvement, even if there is a ventilation improvement on proning. That is what is the message. Then again, in severe ARDS, these are the guidelines, but again, not very commonly they can drive you. So when you consider ECMO, PaO to FaO2 less than 105, but again, it's not, it is a very vague line. Indicated less than 100, yes, of course, but again, I told you, not all patients with the PaO to FaO2 below 100, they should go to ECMO. So this is what the ELSO guideline says. Now, a little bit about the experience, because in the beginning I told you, because there is no much of the robust evidence, so we'll go with our experience, and again we'll go back to our case, what we did there. So of course not that is not the patient, she is a female patient. So yeah. So this is a young patient, viral pneumonia, came to us from Hyderabad. So this is what we have done. One more patient, just another 1 minute maybe. So yeah, now this is the, sorry, this is the patient who I am talking about, 33-year young lady with 2 kids came. So we initiated ECMO, proned for another 2 proning sessions. Then subsequently we decannulated her on day 17, and she is running some interior designer company basically. Right now she is from Hyderabad, and there are so many patients. This is the small kid we had initiated long back in 2016. So for same viral pneumonia ARDS, this is a guy from Lucknow. We had initiated ECMO and brought. We discussed. This guy is from and from Vijayawada. Came to us on ventilator, was an ECMO, was discharged. Then yeah, this is one more guy, same VV ECMO. This is one atypical case. Patient having dengue shock, ARDS, myocarditis. We initiated a VA ECMO. So again in Apollo, so this is basically our team, and was discharged. This patient, we went to Bhubaneswar, initiated ECMO and brought, and this is while discharged. This is another person, this is a very famous person, having some again, some company in Hyderabad, and he was on VA. This lady is on VA ECMO. Recently we discharged. This is one more lady, and on viral pneumonia on VA ECMO. So yeah, this patient is from Patna. Again same viral pneumonia ARDS, was discharged. This guy, it's like a he lost election, but subsequently nothing to do with the viral pneumonia with the election. But we now the reason why I am telling it. So we initiated ECMO from Bhubaneswar, brought here, was on a tube. So when we extubated, he told a typical story. He felt that his opponent, he is from the BJP, basically he felt the Congress people, they like abducted him, put a pipe in his mouth and have kept. And again he went back to, he is the Chief Minister of Orissa. Again he fought election and he became the MLA. Okay. So yeah, this is the guy. This is recently, I think 2 days back, we discharged this girl. Now this is our eCPR survived. The patient had a cardiac arrest. We initiated VA ECMO, and subsequently she came back. But again, it's not like that everything is greenery. We have lost so many patients. In the beginning, in 2015, 16 till 17, when we were doing ECMO, those were the learning curves. I still remember so many young patients we had lost, but it's doable. I mean to say, once the program you start, you enroll those things, the learning curve is faster, and again it is like you escape from the roller coaster drive of the amusement park. You get that excitement, then comes the celebration. Thank you. Any questions we can take?
Thank you, doctor, for that wonderful presentation. Floor open for questions.